Gerardi of Advanced Urology. I'm here with Dr. Matthew Fakhoury, who is a colleague and friend of mine, and we're here to talk about men's sexual wellness tonight. I welcome everybody to the group. Looking forward to an informative session tonight. Hopefully we can answer whatever questions may come up. If you have any questions, you can just post them and we'll try to get to as many as possible. All right, so let's get started. So just a little bit of background. My training was at SUNY Brooklyn. Did my residency at NYU, spent some time at Memorial Sloan Kettering. I do mostly BPH work, urologic oncology, mostly prostate cancer, some minimally invasive procedures, usually for BPH. And I'm actually the director of men's health for Advanced Urology. We have a relationship with Mount Sinai as an academic affiliation. We also have relationships for patient referral for advanced prostate cancer and other groups locally. Our offices, Dr. Fakhoury and I, though Dr. Fakhoury has several more than locations than I go to. I'm in Bronxville, Manhattan, and Yonkers, North Division. Okay. So when we discuss sexual health, I mean, I think for some people it means different things than for other people. But for the most part, I think we kind of have a general idea of what it is. It's important for overall, physical, personal relationships, self-confidence, and obviously personal satisfaction. This is a study that was done in 2019 that you can read there. So I think, so women are more knowledgeable about sexual health than men. You may argue that women are probably more knowledgeable about most things than men. But women are more likely to seek sexual health and to actually, men are traditionally more like stoic, for example, most especially older men who were not brought up in an era of Viagra before the advent of Viagra, like 35 years ago. A lot of men never even talked about it, and most men are still somewhat reluctant to talk about it. So why discuss it? Back there. So it's a very common concern. I think Dr. Fakhoury would agree that nowadays we see more younger men with a lot of sexual dysfunction. I think a lot of it stems around anxiety, a lot of pressure on the younger population. But you can read the slide here. 44% of men are worried about erectile dysfunction. 39% of men are worried about loss of sex drive, which we'll get to. And 36% of men are worried about low testosterone. And I would argue that number is actually even higher. We have a lot of men that are seeking out testosterone replacement therapy in all its different forms that we provide. So here's what we're going to cover tonight: premature ejaculation, vasectomy procedures, infertility, low T, and PD, Peyronie's disease. And Dr. Fakhoury is going to get into a lot of ED treatments. So premature ejaculation, I think a lot of people don't, may think that that's the case, but on average, most premature ejaculation is probably, or the normal time to ejaculation is probably about 1.5 minutes to 2 minutes. I think most people are surprised to hear that fact. One of the most common forms of male sexual dysfunction, it occurs when a man climaxes before he wants, typically within 1 minute of the initiation of sexual intercourse. And it does provide a lot of emotional stress to the relationship, to self, to self-esteem, and it can really weigh on a relationship. So especially with a new partner, it creates a lot of anxiety, guilt, even depression, and a lot of it can be it can be treated very effectively either through counseling or through medical treatments. Behavioral change is one way, so we can try to have patients kind of relax, or there's something called a start-stop technique, counseling and behavioral therapy, cutting back on triggers such as alcohol, tobacco, or drug use, medical therapy, certain antidepressants. We take advantage of the side effect, which is to prolong ejaculation. And that actually works fairly well. The thing is, you can't take it as needed. You should really take it on a more regular basis, usually initially every day. Some of the topical anesthetic creams and gels can be a little bit messy, but they can be effective. A lot of patients aren't really too fond of those types of treatments, though. Okay, so Peyronie's disease, I think we see a lot of that advertised on TV. It's pretty popular. It's one of the things that, in the last several years has become much more, not necessarily more prevalent, but more in public awareness and more to our awareness. And patients are coming in that would never even thought about even mentioning to anybody years ago. It's a condition that causes penile curvature, indentation, and the loss of length upon erection. So basically curvature due to scar tissue of the two corporal bodies, which are the spongiosa of the corpora cavernosa of the penis. It's more common over 50 years of age and underlying medical conditions. And it's still definitely way undertreated. A lot of patients are still very reluctant to come and seek treatment for it. The studies say about 6 to 10% of men have Peyronie's, but again, I think this is also underestimated. As I mentioned, penis bends during erection. You can actually lose size because the corpora do not extend fully. People can actually get pain, and erectile dysfunction is very common. Treatment includes traction devices, which work. It's kind of when you tell people about it, sometimes they're very reluctant to do something like that. But the curvature always goes in the direction of the plaque, as you can see on the diagram. So that's the corpora, and the spongiosa is actually around the urethra. But the plaque always causes curvature in the area, in the direction of the plaque. So the treatments are injecting medications into the plaque. The newest one is Xiaflex, which is an enzyme that breaks up the plaque. Previously, we used calcium channel blocker called verapamil, which we still use now in some cases. And it's office-based treatments that are very small needle injection into the plaque to try to achieve dissolution of the plaque. One of the other things that's sometimes used is also daily Cialis to help blood flow, and also not in conjunction, but penile pumps, which can help blood flow to kind of force blood flow into the corpora and help to basically try to dissolve the plaque. Surgery is kind of a last resort. So basically, there's ways to remove the plaque and different grafting techniques, to basically cover the area that you're excising. These are done on a much rarer basis. Okay, vasectomies. I know a lot of people, have an idea what vasectomy is. We'll go through kind of the technical part. It creates a permanent solution for people that want to have to be sterile without kind of daily types of treatments. It is performed in the office. I did 2 today on their local we use nitrous in the office a lot of times, which is basically laughing gas to kind of relax the patient. The procedure takes literally about 10 to 15 minutes. We use a local block as well as a nitrous. Some patients like to be put to sleep for it, which we do offer that in certain cases. So basically, the recovery is just basically a few days. For people that do strenuous activity, maybe a little bit longer. It's really quick, simple. We just take make a little slit in the skin, or sometimes not even using the scalpeless technique or with a small scalpel. And then we pull up the vas, just basically cut it, cauterize it, tie it, and put a little stitch or glue into the skin. So the nice thing about vasectomies, so the testicle actually only contributes about 10% of the semen volume. So most patients don't even appreciate any loss in semen volume. It doesn't affect sexual function, sexual desire, hormones, or anything like that. The little slit, you can't even find it afterwards. But of note that it does not prevent STDs. And a lot, if for some reason down the road a patient decides they want to conceive, a lot of times they go right to IVF, because you can still take sperm directly from the testicle, or you can do what's called a vasovasostomy, which is a microsurgical procedure that reconnects the vas. Okay, so fertility. Okay, so male factor fertility, 30 to 50% of cases stem from male-related problems. I think fundamentally we kind of look at this as we want to optimize both partners. It's not necessarily one person's fault or the other person's the problem. It's a matter of optimizing both partners. Fertility can be, starting from all these causes you can see here, hormonal, obviously physical blockage of sperm, varicocele which is dilated veins, can slow sperm motility and quality, undescended testicles, low sperm counts and low motility, and genetic causes. I mean, people just kind of assume that they're fertile, and some people just have a lower fertility, lower capability. For diagnosis, we do basically three things. Semen analysis, obviously, after abstaining for a few days. We do urinalysis basically on most patients that come into the office. Blood tests for hormones to assess testosterone, and mainly FSH, which is follicle stimulating hormone. So that gives a good idea of whether someone is fertile. If a varicocele is suspected and someone has a low motility, we can address that issue as well. And sometimes we need to do biopsy to see if there's, let's say someone is azospermic, meaning there's no sperm. We can do a biopsy to help diagnose the problem. Like in most things, lifestyle, healthy diet, avoiding certain adverse risk factors, and exercise are always pretty much for everything. So again, varicocele that require usually with surgical, a small surgical procedure. There are some endoscopic varicocele treatments, and for obstructed ejaculatory ducts, there are treatments for that as well. So low T. So this is something that is very popular. It's very in the media. It's advertised a lot. More and more patients are coming in for hormonal treatment. So the term, most people know the term menopause, but men go through andropause, which starts out in the 30s, where the testosterone level, the male hormone, the basic male hormone, starts decreasing over time. Most men will notice these symptoms of fatigue, decreased muscle strength, prolonged recovery, increased body fat, sometimes hair loss, problems with sleeping, hot flashes, decreased libido, and then mental issues like just basically feeling kind of depressed, not motivated, lack of self-esteem, inability to focus. People describe what they call like a brain fog. They just don't feel as alert as they did when they were with higher levels. The other thing that's not on here is actually joint pain. I think especially in the older population, that's almost, I think, more universal than anything, that they have an improvement in joint pain. Low T is not just for sexual health. It aids in bone health, cardiac health, mental health. psychological health. Anyone whose testosterone is in the low normal range may benefit from treatment, but it definitely should be managed professionally and not like from your gym partner. So one of the things I'll just mention about testosterone, if you get the labs back, I mean, there's a huge range, usually like 250 to 800 for total testosterone. Some people need 300, some people need 800. So there's other factors. We like to look at a number in a lab value to point to, but there's receptor affinities, substances that bind to testosterone that make it inactive. So that's why the range is so high. So a lot of times we treat the clinical response and not necessarily treat the lab values. It's important, I think, so treatments vary, and we provide all the treatments. Like most of us provide all these treatments. Obviously, oral meds, sprays, patches, pellets, injections, whether it's weekly or after several weeks. Some of them last several weeks. And some of the transdermal gels are popular in daily gels.
And just one, perfect timing. Dr. Gerardi, perfect. Thank you so much for the
Did you want to say something, Matt?
great deal of information. Yeah. So just with respect to testosterone, as Dr. Gerardi said, it's not just about managing sexual function. We know that testosterone is cardioprotective, and unfortunately, it did have a moment in time where it had a bad rap because it was misused. There's no doubt about it. But for the first time ever, the FDA removed the black box warning off of testosterone replacement therapy because there was a concern that it could cause cardiac dysfunction and strokes and things of that nature, which is, we know for sure, is no longer the case. We know that testosterone replacement therapy is in fact cardioprotective. So we encourage you guys to speak to either your primary care physicians about getting a urology referral, going to see your local urologist, because a low testosterone can affect many facets of your life and quality of life at that. So with that transition.
Yeah, I was going to say, and to add to that, it's actually protective in ways because it decreases your body fat. It increases lean muscle mass and patient activity and recovery.
Absolutely.
All right. Let me bring you into your slide.
Thanks again, Dr. Gerardi. So, as Dr. Gerardi said, I'm Matt Fakhoury. We're both partners at Advanced Urology Centers in New York. Board certified urologist from Westchester, born and raised here. I did my residency in Chicago's Cook County Hospital. My my passion is sexual function and men's health. We treat a range of kidney stones, BPH, trouble urinating, urinary incontinence. A center of excellence for penile implantation and BPH procedures. I've been well published in the area when it comes to sexual function. It's something that I'm passionate about. And unfortunately, it is a taboo topic for a lot of men and their partners. And what we're here to do today is trying to shed some light and make it very clear that this is a topic that should be discussed openly, because there's only one way to advance and make sure that you're getting the care that you need. And the first step is discussing it with your urologist. So my practice locations: Bronxville, Yonkers, and Throgs Neck in the Bronx. So this is a great transition, being that we just finished up with low testosterone to talk about erectile dysfunction. Obviously, one of the most sensitive topics that a partner can have at home as far as conversations go, and one of the most sensitive topics to talk about within a clinical setting. So what we're trying to do is make this more natural, so to speak, so that patients feel comfortable in bringing this up to their physicians. So erectile dysfunction. The number is probably tremendously underreported. Why? Because it's such a sensitive topic to discuss. So erectile dysfunction is the ongoing inability to achieve or maintain an erection long enough to have sexual intercourse, and take it a step further, to provide satisfaction to either you or your partner. Approximately 1 in 5 men over the age of 20 experience erectile dysfunction in their lifetime. I'm sure that number is much higher. More than half of men have some degree of erectile dysfunction, and approximately 40% of men will be affected by the age of 40. 30 million men in America have reported to have some kind of erectile dysfunction. Again, we think these numbers are tremendously underreported. So how does an erection work? I when I speak to my patients about it, I'm sure Dr. Gerardi does the same. There's really two parts in erection. There's getting the erection and then maintaining the erection, which is the harder part, pun intended. An erection is a complex interplay between arteries, veins, and nerves in the penis. Blood flows in and blood flows out. We need obviously stimulation of some sort. The muscles around the arteries end up relaxing, which drives more blood flow into the penis. As Dr. Gerardi was talking about earlier, the corpora cavernosa. There's 3 tubes in the penis. The 2 tubes that we're focused on right now are the corpora cavernosa, which you can see in this slide at the top right corner. Additional blood makes the penis stiff and hard or erect. And then as the erection develops, the veins basically stop the blood from escaping out. But one of the issues that men may have is a venous insufficiency, where that blood can no longer be trapped in the penis, thereby causing a flaccid state. So, common causes of erectile dysfunction. Whatever is good for your heart is good for your penis. Whatever is bad for your heart is essentially bad for your penis. Okay. And that's the way you guys should be thinking about it overall. 70% is related to overall poor health, whether it's vascular disease, diabetes, obesity, smoking, drinking. All of these things that your cardiologist talks to you about are pretty much the same conversation that we have with our patients. Okay. How do you reduce your risk of developing erectile dysfunction? Maintaining a healthy diet, exercising regularly, losing weight, limiting the amount of alcohol. Your penis does not want you to smoke. Your penis wants you to quit smoking. All right. Reduce stress and making sure that you're getting appropriate sleep. And a lot of these also tie into the discussion that we had a little bit earlier with respect to testosterone levels. 30% of erectile dysfunction can also stem from medications. Patients that have underwent some type of pelvic therapy, pelvic surgery in the past, such as a radical prostatectomy, the removal of the bladder or removal of the prostate because of cancer. Low testosterone, as we discussed, radiation therapy, again, for some oncological reason. Depression, anxiety, that's a big one. Do not underestimate the role of psychogenic erectile dysfunction, which is basically where if the big head and the little head are not on the same page, things are just not going to go well. And we'll talk a little bit more about that later. And again, the treatments for prostate cancer. So erectile dysfunction and diabetes, okay? According to 2012 census, 15 million men in the United States have diabetes. Probably all of those men that reported diabetes also have some degree of erectile dysfunction. Erectile dysfunction occurs 10 to 15 years earlier in men with diabetes. And ED's prevalence is 3 times higher in men with diabetes, or diabetes being that your sugar is no longer controlled. Erectile dysfunction occurs earlier in those men. And it actually does get worse as the diabetes goes on, especially when it is not controlled. Heart disease. This is a big one. Erectile dysfunction can be an indicator of silent coronary artery disease. One of the first places that we can pick up a heart attack that's pending within 5 years is actually through the penis, because if the penile arteries have some sort of degree of calcification or coronary artery disease as the heart would, then we can pick up that this patient is at higher risk of some kind of cardiac event in the next 4 to 5 years. Erectile dysfunction precedes coronary artery disease symptoms in almost 70% of cases. And I believe there's a slide just discussing the anatomy, which it's a really important point, and we'll get to it in a minute. Okay, this is it. So erectile dysfunction often presents before the symptoms of heart disease, okay? If we're looking at this slide here, basically entailing the anatomy of the vessels within our body, okay, you can see that the artery size of the penile artery is actually one of the smallest arteries in the male body. So what is going to get affected first if a patient has coronary artery disease? It's the smallest artery, which again is the penile artery, okay? And we can actually diagnose this in our office. We perform specialized ultrasounds of the penis in order to demonstrate blood flow going to the penis and how much of that blood flow is exiting the penis. And we can pick up on calcifications through that ultrasound. Erectile dysfunction can be the canary in the coal mine for heart disease. And we know that any blockage that's caused by the heart will stop blood flow going to the penis, which is essentially why erectile dysfunction can happen. Okay, that's the arterial disease of erectile dysfunction, and we talked a little bit about the venous insufficiency as well. Treatments. So there is an algorithmic approach to erectile dysfunction. Okay, the first step again is actually bringing it up to your physician. The second part is figuring out what dietary behavior modifications you can make, exercises, and begin to talk about some of the therapies and treatments, such as oral medications, which are basically available anywhere online. Okay, but again, I would consult your urologist before you start these medications, or your cardiologist. So the goal of the medication with respect to erectile dysfunction treatment is to increase blood flow to the penis. You still have to have some kind of stimulation in order for that to happen, because it's a trifecta. You have nerves, arteries, and veins that work in tandem in order to develop a good erection. Okay. The erectile dysfunction treatments are effective for the right patient, and sometimes they just don't work because, unfortunately, the damage has happened already. It's not as effective for men with diabetes or patients who've had prostate surgery in the past. It's sometimes covered by insurance. That all depends. And it takes about an hour to work. We tell our patients take the medication an hour before intercourse. Sometimes we tell you not to take any medication, not to have any food in the system, because it actually changes the absorption of the medication, especially with Viagra. Okay, and it could last up to 4 to 36 hours, depending on the medication that's used. Some of the side effects we hear about from our patients: headaches, facial flushing, sometimes muscle soreness, nasal congestion, especially in this area here, vision changes, and a prolonged erection, or priapism, is an erection that lasts more than 4 hours, which is a true surgical emergency that you have to go to the emergency room for. Vacuum erection device. These are effective, but they do require some work, and they're not cheap. But for the right patient, it is very effective. And what we're doing is essentially trying to bring more blood into the penis using this vacuum erection device. Effective for about 60 to 70% of men, I would say. 80% might be pushing it. Not 86% of men decide to move on to other treatments due to the lack of being able to have a spontaneous erection, discomfort, or insufficient rigidity. That's a very, very accurate statement. Okay. And as I said, how it works, you basically have this tube that goes over the penis. It's usually battery operated. And there is a constriction device that stops it at a certain point, so that you're not causing any hematomas or any swelling inside the penis. Injection therapy. Okay. So injection therapy is basically where we teach the patient, we teach you guys how to inject your penis at home. Okay. The first time it's done, it's usually done in our office under supervision. So we make sure that you're doing this correctly and injecting in the right area. All right. These are overall pretty effective, and there's different dosages that we can provide for patients. And one of which is Trimix. Okay. It's a self-injection medication that goes directly into the penis. It sounds terrible, but it's not that bad. It's a very, very tiny needle. The erection can initiate basically in about 5 to 20 minutes prior to intercourse. Does need to be refrigerated, does have a limited shelf life, so you want to use it when you get it. And it's usually developed, it's usually made in a compounding pharmacy, which we assist our patients with obtaining. Why do men not like the idea of injecting their penis? I mean, it's needless to say, pain, development of scar tissue. Dr. Gerardi touched up on with Peyronie's disease. You can actually cause a calcification in the penis because of the injections as a result of the needle itself. I mean, you take a needle and stick it into a sheetrock wall, eventually the wall is going to change. So your penile tissue will react the same kind of way, and you can cause a penile curvature or plaque formation. Blood collection and unsatisfactory results. Okay. Dr. Gerardi is offering low intensity shockwave therapy for erectile dysfunction. We like this. It's minimally invasive. It's cost effective, and we know that it does work, but it works for the right patient. Okay. If the patient is taking multiple oral medications and Trimix injections, it's unlikely that this is going to be as effective. But patients are more than welcome to try it, because it's essentially a shockwave therapy that's delivered to the penile tissue in order to increase blood flow going to the penis. It is not painful. It is effective. Unfortunately, insurance companies don't cover for this, but it is available. Okay, it's a focused, low-intensity shockwave. It does require multiple treatments, clinically validated to stimulate better blood flow to the penis, and it's ultrasound focal versus radio wave, which allows us to target some of the tissue and the blood vessels more specifically. No expected side effects, no downtime, no pain, potential to elimination of erectile dysfunction medications, and can be a longer lasting treatment. So this is where I want to spend most of my time, and it's for the placement of a 3-piece inflatable penile implant for erectile dysfunction. Typically, this is a surgery that we do in the hospital. There are two types of penile implants that men can get. One is a malleable, which is basically where your penis becomes more of a lever, and you lift it up when you want to achieve an erection, and then you can put it back down. Less natural feeling, less natural looking. But for men who have dexterity issues, meaning they can't control their fingers very well, it's a great option, and it does restore a patient's quality sex life back into their relationships, because they are able to achieve some sort of erection. Okay. The inflatable penile implant is a 3-piece implant that's placed surgically. It's completely hidden to the naked eye. Nobody knows you have this in place. Okay. And it's self-contained. It's a fluid-filled hydraulic pump, essentially. 2 cylinders. We talked about the 2 tubes that carry the blood, the corpora cavernosa. Essentially, these cylinders get inserted into the corpora cavernosa which allows the male not to have to rely on blood flow in order to achieve an erection. You control it yourself through this hydraulic system. Okay. And essentially what you're doing, if you look in the top right-hand corner, we'll go through a video shortly. There's a reservoir, there is 2 cylinders, and there's a scrotal pump. The scrotal pump sits in the scrotum. It doesn't really touch the testicles. Okay. But we basically allow the erection to occur as a result of pumping on the scrotal pump to deliver fluid from the reservoir into the corporal bodies to essentially get a 10 out of 10 erection each and every time that you want it. Okay. So the 90%, if you see at the bottom of the slide, 90% of men satisfied with erections. It's actually a little bit higher than that for both men and their partners. Okay. It's actually closer to 95%. Out of all the prosthetics that we place in patients, whether it's hip, knees, or any of the sorts, the penile implant actually has been shown to last the longest. There are patients who are walking around with implants that have been in there for 20 years and they're still functioning. Okay. There's very few things that we can put in the human body that last that long. Okay. What are the risks that we talk about? Obviously, the scariest one that we worry about is risk of infection. Okay. We do things a certain way, the exact way, every single time we do the surgery in order to avoid any risk of infection. Okay. There are certain aspects of the surgery that cannot be denied, that have to be done a certain way to reduce the risk of anybody developing an infection after a penile implant. Okay. There's potential to device failure. There is, unfortunately, there's conversations that we have with patients sometimes. Well, doc, my penis it's erect and I'm able to achieve an erection, but it's not as big as it once was. And the conversation is a really important one to have with our penile implant patients, because we have to manage expectations. Okay. The goal of the implant is for you to be able to have an erection anytime, anywhere. Okay. You want the erection to last for 10 minutes or an hour. That's completely up to you. And you have that ability now. But what it is not for is for you to increase length or increase size of the penis. That is not the goal of the surgery. And I can't stress that enough. We're going to play this video. So this is the pumping mechanism where we're delivering fluid from the reservoir into the cylinders that allows us to achieve the erection. Okay. This is by far the most reliable and most reproducible erection a man can achieve that has been through the journey of erectile dysfunction. There really isn't anything that can replace something like this. Okay. You will not have to worry about taking your medication. Did I take it at the right time? Should I not have eaten? Is it going to work tonight? Is it not going to work tonight? Those questions and those moments of self-doubt will no longer be relevant to a man with a penile implant. So I know we have quite a few questions here. Dr. Gerardi and I will get through as many as we possibly can. Do you want to start, Dr. Gerardi?
Yeah, I can take the first one. So the first question here is, what could the issue be if you ejaculate prematurely with one partner but not another? I think we touched on that. I think that usually is more of a social setting, new partner, for whatever reason, anxiety. Maybe someone hasn't been sexually active in a long time, and now for the first time, they're kind of a little shy. I think there's a lot of social issues that go with that, one versus the other. But sometimes you can treat erectile dysfunction, obviously, with either daily Cialis, Viagra, or Cialis as needed, but also sometimes beta blockers for patients with really severe anxiety. Those are shown to be effective as well, because it decreases the anxiety response. Okay.
If I could just add to that, Dr. Gerardi.
Sure.
So with respect to the psychogenic component of erectile dysfunction, where we basically said that if the big head and the little head aren't on the same page, what I meant by that is your penis doesn't like to be on a stage and perform. That's the last thing your penis wants. It doesn't like the pressure. It doesn't like the anxiety. You got to go into a sexual encounter or an intimate moment with having less pressure on the penis to perform. Because what ends up happening is as men, we get into a fight or flight response. Okay. And when that anxiety builds up, your body's worried about running from the bear more so than your erection. So the last place that your heart is going to send blood is your penis, because you have adrenaline running through your system. So you got to go into the encounter, into the moment as calm, cool, relaxed. And those are the things that are really going to help, especially with the psychogenic component and the premature ejaculation, especially with two different partners. It really does rely on the amount of anxiety and the social awareness, just like Dr. Gerardi said.
Thanks, Dr. Fakhoury. Okay, next question. How frequently must these injections be administered? I'm assuming that's for testosterone.
I think it was the Peyronie's, Dr. Gerardi, for the
Oh,
Xiaflex.
oh, is it? Okay. You want to take that one then?
Yeah, so the Xiaflex injections, if I'm not mistaken, I hope I'm not wrong here, but regarding the Xiaflex injections, it's usually a series of about 6 injections. The first injection is given, they're all given in the office by your urologist, and they're given directly into the plaque on day 1, and then you'll follow up the day after, 2 days later, excuse me, and get the second injection. And we ask our patients to take pictures, pay attention to the curvature itself, and then there's a series of 4 more injections depending on what the improvement in the curvature is.
Okay. The next one is about vasectomies. What happens to the testis afterwards? Do they stop producing sperm? So no, they do not stop producing sperm. Before a vasectomy, there's something called the sperm or the testis blood barrier, where the sperm is actually foreign in a way to your own body. After the vasectomy, the sperm violates that barrier, and it goes into your circulation and is basically cleansed by the liver and the spleen. As I mentioned before, so some people, for certain, after vasectomy, if they decide they want to have conceive afterwards, that is an option to actually take sperm directly from the testicle or do a surgical procedure to actually reverse the vasectomy.
Next question we have here is testosterone and prostate cancer risks. Great question. When we talk about patients with a risk potentially of prostate cancer, we obviously would concern ourselves with the testosterone levels. If prostate cancer was a fire in your body, the fuel to that fire, the gasoline, is actually testosterone. So one of our goals, especially in the advanced prostate cancer setting, is to shut down the production of the testosterone. Dr. Gerardi, you want to add to that?
Yeah, so a lot of patients are treated with what we call neoadjuvant hormones for prostate cancer. So we want to decrease the testosterone level of people with higher grade, higher stage prostate cancer. But having said that, patients that are effectively treated and have no evidence of disease and had been, let's say, on hormones to lower their testosterone, more recently, we're actually starting to replace the testosterone in those patients who are very symptomatic with the symptoms that we described before of fatigue and loss of mental acuity and these types of things that we talked about before. If they're very symptomatic, we can actually replace the testosterone carefully and monitor their levels to make sure that it's safe. Go ahead.
what is the is there any truth to the interplay between muscle tone, Kegels, and erectile dysfunction? Uh, yes, I mean, I do think so. I think the pelvic floor is partly responsible for developing a solid, healthy erection. So things such as Kegel exercises, yoga, anything that helps the pelvic floor muscles develop, okay, will intensify erections and especially intensify ejaculation. Dr. Gerardi,
Agreed.
we have another question here.
Let's get to, I think we have some more coming up.
Oh yeah, we do. Okay. Does
Um,
the implant replace the corpus cavernosa? So what you prior to a penile implant, what you come into the operating room with, you still leave with. Nothing is removed, only added. The corpus cavernosal bodies remain intact, but what we do is we create a small incision in each corporal body to allow the cylinder to go inside of there. And then we basically close it back up. So you still have your corporal body, but it's no longer relying on blood flow in order to achieve an erection. Good question.
Next question. I had aquablation surgery for BPH 2 years ago. I'm pleased with the result. I'm 71 and no longer have ejaculation. I'm not concerned about it, but should I be? So basically, after a lot of several BPH procedures, prostate enlargement procedures, when you resect the prostate or treat the prostate, the semen then goes into the bladder. It's called retrograde ejaculation. So, and when you urinate the next time, it washes out. So there's no downside to it. You should not be concerned about it. More of a social issue. Some people are bothered by it. Some people don't care about it. That's obviously a very important conversation we have before any BPH treatment, as this can be a side effect. Next one, can shockwave therapy help with Peyronie's? It does not help the actual curvature. It can help with Peyronie's pain. So patients that have pain with erections, painful Peyronie's, it can help with discomfort for those patients.
Does taking testosterone supplement make you more susceptible to prostatic cancer? That was something that was debunked by the American Urologic Association, which is why we're comfortable in giving patients back the testosterone replacement therapy after the prostate cancer has been completely eradicated.
Was there more?
How does the testosterone work? I'm 54. I'm a 54-year-old male. I've had prostate cancer. I'm currently taking Cialis. Side effects, I don't like it. So you've had prostate cancer, and I assume it was treated. You're taking the daily Cialis 5 milligram. You have some side effects. You got to come in and talk to your urologist. I mean, that's step one. Come in and talk to your urologist. Make an appointment with your local urologist so that you can see if you're a candidate for testosterone replacement therapy after your prostate cancer has been treated.
Yeah, just to add to that, I mean, each patient has their own concerns, their own clinical situation. It's really important to identify exactly what the goals are, especially with hormone replacement. Patients come in and they want to take growth hormone, they want to take, Somorelin. Now peptides are very, very popular. So, I always try to back it up and say, look, what is your end goal? What is the goal here? What is the end point? And a lot of times they don't need to take a lot of these more risky, medications and treatments, because testosterone really does get to a majority of where they want to be.
Right, and we want to treat the patient, not just the number. So a testosterone level for one guy may be very, very satisfactory versus another guy where that same number just isn't giving him the same kind of benefit. And our goal is to treat the patient holistically rather than just the number itself or the lab value. But it is very helpful. I think we've reached the end of the questions here. If anybody has any last minute questions, please feel free. Otherwise, we really thank you for your time. We appreciate you guys bringing a little more attention to this, and we look forward to seeing some of you in our offices at Advanced Urology Centers in New York.
Yes, thank you for joining us. And if you have any further questions, please feel free to contact us. The numbers are listed there.
We thank you all.
Have a good evening.
Dr. Gerardi, thank you.
Thank you, Dr. Fakhoury.
Bye-bye. Good night, everybody.